Hi, thanks for joining us today. My name is Nicole, and on behalf of Megan, I'd like to welcome you all to this Megan Masterclass with our guest, Dr. Roozbeh Rezaie. I'd like to ask attendees to please use the Q&A button on your screen to send in questions at any time during the Masterclass. There will be time for our guests to answer any questions at the end of this session. This webinar will be available to watch on demand on our website at a later date. So it gives me great pleasure to hand over to Dr. Roozbeh Rezaie, who will officially kick off the webinar. Thank you.
Well, good morning, everyone, or depending where you're joining from, good afternoon. Thank you for joining us for this seminar, which I hope will be very didactic and informative for those who are interested in performing language mapping clinically in MEG, or for those of our attendees who were not able to partake in the Megan Wise Technologist workshop earlier in the year, where we touched on this theme. So thank you to Megan for arranging this, and I hope this stimulates some discussion towards the end and forces users to think about some of the challenges and some of the improvements that can be made, including for experienced users in performing language mapping and functional mapping in general in clinical populations using MEG. So I have no conflicts of interest to declare in relation to the invitation to participate in this seminar. Just wanted to get that out the way. And what I really hope that this seminar would do is be didactic in nature, but really provide you with a center-based experience on how we perform language mapping in clinical populations, with an emphasis on pediatrics, which might be a departure from what some of our other attendees may deal with, or have a more mixed-use practice of doing adults and adolescents and younger children. So the take-home really is, what are the fundamentals, at least based on our experience of doing language mapping with MEG in clinical populations, mainly patients with brain tumor and epilepsy, and describe practically how MEG is used to determine the location of language-specific cortex and determine laterality for speech in patients with brain tumors and epilepsy, a subset of which undergo surgery for treatment, which might be germane to a lot of the attendees who are on this seminar, based on the volume of surgical cases that they encounter through their MEG program. One of the emphasis of this talk, and practically the crux of the presentation, will be the approaches in terms of paradigms that are adopted, or at least we adopt, to perform language mapping, and how we interpret the data and what the implications are. And we'll do this through several cases where we frequently encounter the referral question of where's language organized, what is laterality, and what the implications are for these patients. Lastly, we'd like to review some of the validity associated with the particular protocol that we use, and again, stimulate some discussion about what are the capabilities, what are the potentials, what are the limitations, how, even as an experience center like ourselves, we can strive to improve what we do and maximize the capability of MEG for performing functional mapping in clinical populations. So just to give you a brief overview of the organization of the talk, and forgive me if this is somewhat rudimentary for some of our users that might be more experienced, but you know, we'd rather err on the side of caution and be a bit introductory in the way that we organize and present this talk. So we'll just go through the neuroanatomical models of language in a very simplified way, which form the basis of how MEG language mapping has developed, what the nature of the activation is, basically what constitute language-related fields, what are the activation procedures and paradigms that are used for doing language mapping. Again, I have to emphasize that this is more of a center-based approach, so there might be a divergence from how other centers approach this, or if users are new and interested in performing this sort of mapping with MEG, what are the options that are available. We'll discuss recording parameters, data review and analysis, some of the more practical aspects and more hands-on dimensions of performing language mapping. Then, as I mentioned earlier, we'll talk about what are some of the referral questions, where we might encounter the need or the request by a surgeon or neurologist, namely an epileptologist, on performing language mapping, show it in practice with the case studies, and discuss what are some of the caveats that we encounter in doing language mapping, particularly in pediatric populations. And we will round it off with a discussion, which I hope will be interactive, regarding the validity of MEG for performing language mapping and what the consensus is, at least what our view is and what the opinions of other users might be, and discuss what are some of the limitations and challenges and how, again, things can be optimized to make full use of this technology for performing functional mapping in patients with epilepsy and brain tumor. So basically, the evolution, very much like it would have been, has been with using metabolic-based imaging methods, functional MRI, PET, and to a large degree, more recently with transcranial magnetic stimulation, is what models of language are we trying to assess? So for people with our attendees that are somewhat familiar with the basic neuroanatomical models, I think most simplified approach would be either the dorsal or ventral root models of language. Of course, when dealing with receptive language, the cardinal regions of interest are, of course, the traditional Wernicke's area, which is the posterior 1/3 of the superior temporal gyrus, and encompassing the supramarginal gyrus, and to some degree, depending on your definitions, parts of the inferior parietal lobe, as well as middle temporal regions, assuming with laterality being in the dominant left hemisphere. In terms of expressive language, that would also include premotor regions, as well as traditional, at least operationally defined, Broca's area, to include Brodmann's areas 44 and 45. I must stipulate here that from our perspective, whether the interest is in mapping receptive or expressive language cortex for the sake of not just determining the extent of that functional cortex, but determining laterality, that there's a significant degree of overlap between regions that are engaged during expressive and receptive processes, particularly areas that might be implicated in semantic access, and the models mainly being distinguished by areas that are involved in the articulatory aspects of speech, which are more relevant to expressive language paradigms. But nevertheless, pre-identification of regions that one would assume would be involved or would be targeted with MEG or suspect would be activated are based roughly on the representation that's in the schematic. So what are language-related fields? They basically represent variations in magnetic flux that are time-locked to a presentation of linguistic stimuli. Now, this could be in either the visual modality, it could be in the auditory modality, and it could, in levels of complexity, it could be something as simple as letter sounds, decoding, printed text, recognition of real words, articulation of objects, verbs, nouns, any sort of task that puts a demand on the systems that were discussed in the previous slide. One thing to remember is in the scheme of performing functional mapping, language-related fields are low-frequency responses that are significantly smaller than, say, epileptiform transients detected on MEG, but also from more robust primary sensory responses that one might encounter in somatosensory evoked fields, auditory evoked fields, and even visually evoked fields. So we're looking at a much more variable response. It characterizes the temporal progression of areas that are engaged in a certain speech process. So basically, if we refer back to the previous slide, we're basically mapping in time the sequential activation or engagement of areas that are involved in cognitive functions or processes that underlie a certain language function, be it receptive or expressive, in association regions. So the other thing to keep in mind is there's a larger variability in the temporal characteristics that are compared to more robust sensory evoked fields, visually evoked fields, auditory evoked fields. So the variability in the engagement of those regions might make it a bit more challenging to obtain reproducible profiles of activation. That's not to say that there are similarities across participants or patients, but it might be the case that certain regions that are active during the course of a paradigm might not all be active in the same individuals, or by and large, you would expect activation in certain regions to be consistent across all individuals under the context of normal variation. We'll get to that when we discuss what we consider to be normative profiles and what the deviations from these are. So paradigm selection. There's a large variability in paradigms that are used across MEG users, and to a degree that could be translated to individuals who might be applying functional MRI or TMS. Less so variability across those modalities. Now, the thing to keep in mind is there's, at least in my opinion, there's no right or wrong way of doing it. It just depends what the referral question is and what you're interested in mapping. So if there's specific circuits that you're interested in mapping, say for example, traditional Wernicke's area or the inferior frontal gyrus, premotor cortex, particularly as it concerns the articulation of speech, your paradigms will be based on what it is that you're trying to elicit. Now, hemispheric dominance is something that's based on those. The localization or mapping the extent of the language-specific cortex is really what drives the selection of these paradigms. Again, going back to what we said earlier, it's more likely than not that irrespective of paradigm, if language as a whole is being addressed, there will be overlap between regions that are engaged. So this is one thing to keep in mind when selecting what approach to use in terms of paradigms, is exactly what it is that you're interested in looking at, what regional activation. So in our experience, things that should drive selection of a specific protocol are: what are the mechanisms of interest? Are you interested in looking at receptive language, expressive language, a paradigm that might be able to address both, or dissociating the two functions? Now, by and large, there should, in terms of laterality, there shouldn't be a difference between the two, but there will be subtle differences in engagement of language-related cortex. More nuanced is, are you interested, or are we as a whole interested in looking at how language is represented, i.e. the extent of language-specific cortex, which might be more germane in areas of organic brain disease or space-occupying lesions, or looking at dominance as a whole? Are we just simply interested in assessing which hemisphere is dominant for speech without really placing too much emphasis on the representation, anatomical representation of particular components of speech? Now, if that's the case, I suppose one would be selling short the capabilities of MEG, and for that fact, most imaging modalities. So there's a lot of rich information that's included in the mapping protocols that one might use with MEG. And again, these will all influence how hemispheric dominance is assessed, and we'll get to that when we talk about the interpretability of the data. How reproducible and robust are they? Well, obviously within and across subjects, reproducibility is something that's desirable. We all have to be cognizant of the fact that task demands and time constraints might make this challenging, particularly in younger participants where their attention span is small, or clinical populations where there might be comorbidity of behavioral disorders that might make it difficult for patients to comply for longer periods of time. So the question is, what tasks are efficient? What can give us what we're looking for? What are reproducible? And provide robust estimates of laterality. How valid are these tasks? Have they been validated against invasive gold standards? Can they unequivocally recognize or identify a subset of regions that could be also localized using electrocortical stimulation, either intra or extraoperatively, and being on par with the WADA test, for example, for determining which hemisphere is dominant for speech. Titration of tasks, how practical are these? What are the populations we're looking at? Adults, which might not have or encounter the same behavioral difficulties that some pediatric clinical cohorts might, will be able to deal with more challenging tasks. So the number of tasks that can be done, the level of complexity might be more amenable to that population, and the quality of data might be a bit more ideal than what you might get in children, and provide you with more room for pursuing replication and robustness. Whereas with children, tasks would likely need to be catered towards more the rudimentary side, things that are robust but can be done expediently within a reasonable time frame where the subjects wouldn't be distracted or burdened with how conscious they are about their performance. Can these tasks actually tease out components that are different from primary sensory phenomenon? Now, cognitive components tend to, the fields they produce tend to be much more variable just because the speed and manner in which adults, individuals as a whole perform cognitive operations vary. So we'll get to this again towards later in the talk when we discuss localization and the issue of time lock responses. And again, more recently, and given how the field of neuroimaging has evolved, how effective, what is the efficacy of MEG language mapping in comparison to other modalities like functional MRI and TMS? Are they able to generate profiles where they elucidate overlapping components in language systems? Are there dissociations? What are the alternative models that can be tested using each modality? So really having a multimodal approach is something that can bolster or support MEG as a standalone modality for performing language mapping in clinical populations. So again, going back to what I said earlier, by and large, this discussion will emphasize a center-based experience, and for our purposes, and one that we've advocated, not because it's the best way to do it, but something that we found to be very robust and reproducible and reliable for our purposes, and also valid against gold standard techniques, is mapping of receptive language cortex. And this is based on the continuous word recognition paradigm, or more popularly known as the CRM paradigm, where participants undergo receptive language mapping. There are several variations of this paradigm that are in circulation among MEG users. We have found this to be a very robust, very simple task that can be applied to children and adults equally, with comparable results in providing pretty consistent spatiotemporal profiles of language that are very reproducible within and across subjects. Basically, it's a test of verbal memory for those individuals that are attending a seminar who have a background in neuropsychology. It's a variation of the Sternberg task for short-term memory. So basically, you're eliciting activity in receptive language regions based on recognition judgments made for words. And they're standardized stimuli with a variable range of concreteness, and their frequency based on the Pavio correctness scale. So they've been rigidly standardized, and depending on the version of the task that's used, titration is on par with performance capability. We tend to use the same paradigm for children and adults because, again, we find that it gives a very similar yield, and within the time demands of clinical environment works quite well. There's variations that exist, like I said. You might find a more abbreviated version that we use for kids and adults, but of course there's versions that exist in more complex manners for adults. This can be done either in the auditory or visual modality. We will emphasize doing this in the auditory modality. However, visual or printed version of this task is also available, and it's been reported using the printed version that you are able to elicit activity in not just receptive regions, but also expressive language regions, mainly probably in area 44 and 45. It almost works as a sight word task. So the actual emphasis on decoding printed text wouldn't be as demanding as it would be if you were using pseudo words, which might engage more premotor areas, which emphasizes the actual motor component, the articulatory aspect of speech. So, but for our purposes, determining hemispheric dominance and mapping the extent of receptive language cortex, the auditory version of this task has been ideal. There is a bilingual version. We do employ a Spanish version of this task. I'll show you some examples later on the talk of this. With the demographic that we encounter, we find it to be very useful to have on hand, particularly for non-English speakers. Essentially, here's a schematic of how this task works. We present patients with a list of 5 target words, 3 of which are presented here, and patients are asked to encode these words. We next ask them to repeat the words to make sure that they can hear them. They are able to memorize them, and subsequently these are mixed with distractor words, and the subject is instructed to make an index finger raise of the dominant hand every time they encounter one of the target words that they were asked to memorize prior to the scanning session. The encoding of the target words actually takes place inside the scanner. The patient is instructed to repeat the 5 target words. Most are able to do it, but of course there's cases where processing might be slow, particularly in cases of patients who might have developmental delay, epileptic encephalopathies, conditions which might make information processing very slow. Now, an adult version of this task uses 4 times larger number of target words, so it might be more demanding. So for that reason, we found 5 target words to be ideal. Generally, most patients don't have difficulty, at least older patients don't have difficulty encoding these words, but more often than not, we do encounter patients that have find it challenging. So you might have to go through several iterations, but the key is the purpose of the target words is for them to be able to attend. Need be, this task can be done passively. We have similar appreciable level of success doing it in a passive mode. Patients are being presented with linguistic stimuli. So whether actively attending to them or not, the brain is processing linguistic stimuli, unlike pure tones. So the assumption being that whether they want to or not, their brain is engaging areas that are involved in some aspect of receptive speech. The parameters and instructions of the task really depend on several points. So as I said, the baseline encoding and performance of the targets really determines what the ratio of target to distractor words are. In turn, that based on their performance at baseline, that might provoke you to think about whether you want to do this actively or passively. Speech can be subjective, so establishing the physical parameters of the task are also important. We present this binaurally. We want to make sure that subjects can perceive it equally in both ears, make sure that there's no bias and towards one ear or the other. And we do all our recordings in the supine position to minimize head movement from sliding out of the sensor. We also don't want the transducers that are used for stimulation to fall out of the ear. So you also want consistency in the patient's state. So do you determine whether you do this with eyes open or eyes closed? Should be done at the outset. If patients are capable of fixating onto a point, be it a crosshair on the screen, then that's one option. Generally with children, eyes closed state works better. Obviously, it minimizes ocular artifact, contaminating the data. On the other hand, you might have issues where it might lead to saturation of the signal by posterior dominant rhythm, particularly in patients who tend to be a bit more heavily medicated. And so that's really a judgment call that you might want to make. One thing I will preach throughout this talk is whatever you do, irrespective of your adoption of the approach, to do it, be consistent as possible across individuals for the sake of being able to have confidence in the fact that what you're generating in terms of profiles of brain activation have been done in a consistent manner. Of course, that's always easier said than done when you're dealing with pediatric clinical populations, but something to keep in mind. Generally, we sample at the minimum sampling rate of the system for 1 kilohertz, and we set a bandpass of online for viewing of 0.1 to 20 hertz. We find that to be adequate in distinguishing the early sensory response that's associated with the physical characteristic of the stimulus and the late field low frequency response, which is about 200 to 800 milliseconds, which encompasses engagement, or should encompass engagement of language specific cortex. Replication. So we attempt to do a minimum of 2, often 3, and sometimes more, depending on the level of cooperation and the neuropsychological baseline of the patient, to ensure that we have enough replications. Now, in the absence of a space occupying lesion, or no reason to think there's a shift in dominance or representation of language cortex, that might not be an issue. However, if there's reason to suspect that dominance might be mixed, it might be shifted to the traditionally non-dominant hemisphere, or any sort of reorganization, it's very important to have a reproducible profile, because if those sort of fit outside, quote unquote, the normal range of variation, you want to be able to prove that it's not an artifact of the recording technique, that it's genuinely a phenomenon that should be that's biological. It's inherent to the patient's organic state, and preferably it's something that could be corroborated, particularly in those exceptional cases in patients using an alternative modality like functional MRI or TMS. So in all cases, we aim to do replication runs, and I will touch on how reproducible it is and how to address the overlap to assess replicability. So online review and quality control. Obviously, what you can control is surveying task performance. So look at the patient's response profile. If they're doing it actively, meaning that they're responding to the target words using a finger press, a finger lift, or a button press, you want to make sure that this is occurring only in cases where they're supposed to respond. Otherwise, you risk having frivolous responses, not necessarily because of contaminating the cognitive component of the data, but you're introducing unnecessary motor artifact that's going to be time locked to every stimulus. So if you do have continual finger raises in all conditions, or button presses that are random, your evoke field might represent a very smeared dipolar pattern that's averaged and localized to the vicinity of the premotor motor sensory areas. So you want to avoid that. What's the state of arousal? If the patients are performing it in eyes closed, is there an excess of alpha activity in the background that might saturate this? If they're doing it with eyes open, is there frivolous blinking, or is there consistent blinking that might saturate the response? Of course, a lot of this would be dependent also on head size, how close certain senses are to the forehead and things like that, but much way that it would affect the EKG signal in the patient with a short stature. Given that we deal almost exclusively with patients with epilepsy, what are the frequency of interictal epileptiform discharges? I'll show you a phenomenon that's unique that we encounter on occasion, which might occur to this. Is there excess epileptiform activity interictally that might be interfering with task performance? And really, between runs, replication runs, reiterating the task instructions to the patients, asking them if they can remember the target words, if they can comply with what the task demands were, if they remember the instructions that were given, and so on. Now, it would be prudent that if an individual is not performing early during the experiment, during the testing phase, to discontinue and reiterate the task demands and make sure that they are being compliant to the approach that you're emphasizing, and restarting that again. By appropriate filters should also help visualize with the updated averaging the formation of the field. So as the number of stimuli increase and are averaged online, you should start seeing the formation of early, M50 and 100 response, and then the lower frequency late field response that starts about 200 milliseconds and runs to about 800 milliseconds to about 1 second. Now, the early component response, the M50 and 100, is not always visible, and I'll get to why that's the case. It's actually more often than not, it could be very difficult to see with this particular task. So we'll touch on what that looks like, and why that could be challenging, and what's the advisable approach to take in terms of interpreting the presence or absence of that particular component. So here we just we summarize what the typical testing approach would be using this paradigm in patients, and depending on the interstimulus interval, the task can range anywhere between 8 minutes to 15 minutes, depending on the rate of presentation. Again, there's variability even with this task across how users apply it. So post-acquisition review, we've collected the data. What is it that we're looking at? Well, ideally, in the perfect world, we want to retain as many clean trials as possible. So single trial inspection of the data, as cumbersome as might be, is still, in our experience, the best way to address the quality of the data. Besides looking at, electromagnetic noise and sort of more mechanical aspects of artifact that might be present in the signal, there are physiological signals that, again, that are important to rule out. There's typical EKG and EOG artifacts that can be monitored and using various methods reduced from the data later on. But of course, there are things like saturation of the background rhythm in cases where patients are performing the task eyes closed. That might be an issue, particularly when it occurs when the baseline is being subtracted from the post-stimulus period. And of course, as I mentioned, the probability that there might be excess interictal epileptiform discharges within a single trial that might also saturate the signal in the but you end up getting to the spike average. You also want to verify the topography of the artifacts based on their flux distribution. You might have muscle artifact from the clenching of the jaws, or the ballistics of the cardiac signal that might cause gradients in the temporal lobe signals. And of course, if areas of activation you're interested in that are associated, or you're assuming are associated with linguistic networks also fall across those regions, there might be an overlap. So that's something to identify on an individual basis, trial by trial basis. Generally, a rule of thumb is retaining about 115 to 120 clean epochs to have an adequate signal to noise ratio for being able to quantify the late field activity. We found this to be an absolute, minimum. Going below that really degrades the signal, particularly in patients where their brain baseline activity might be affected by a lot of factors, including the regimen of medications, anti-epileptic drugs that they might be on, and so on and so forth. Or you might have patients with massive space-occupying lesions where you have very high amplitude slowing that constitutes the background. So retaining as many clean, quote-unquote, epochs as possible is ideal. Hence, another need for replication to be able to have conditions or runs where you have enough trials to be able to extrapolate meaningful data and perform ideal source localization. We've often encountered this question: do you look at trials differently based on target or distractor words? You can, and certainly you can. Some users actually remove the target words from the distractor words from the final grand average. However, the ratio of the targets to distractors is small, even in cases where you might use more than 5 target words. So to have enough averages based on targets to obtain a meaningful evoke field with adequate SNR might not be enough. So that's something to consider. And similarly, we've been asked, you separate in conditions where you perform this actively, do you separate correct and incorrect trials? Well, the goal of the target words is to make sure that the patient is actually attending to the stimuli, that there's a conscious effort to actually pay attention to the task. Of course, this is at the choice of the user. If you're interested in factoring in reaction time, for example, into the analysis using some sort of higher level analysis, then that's something you might want to consider. But really, whatever your approach is, we emphasize that it's consistent across all your patients. But for our purposes, no, we do not analyze our evoke fields based on correct or incorrect responses. That's not to say that you can't or you shouldn't, but we find that that's worked best for our purposes. So we perform the experiment. Let's view the topography. What is it that we're looking at? What's the final product? What's the ideal situation? This is, of course, it's a presentation, so we're gonna show you things that would constitute quote unquote normative profiles. Of course, these are based on patients, but what are the ideal signals that we see? Generally, what you would end up seeing is, using this particular task, the distribution would show deflection in the sensors that are across the left and right temporal lobes. Of course, based on that, it's not easy to see what the spatial profile of activation underlying those temporal deflections in each of those hemispheres would be, but this is an ideal scenario of what the signal should look like. We're going to go ahead and amplify one channel, which shows a very nice M50, M100 response, followed by a late field deflection, which constitutes the portion of the waveform where the analysis of language-related fields will be performed. So if we go ahead and we look at the dipolar pattern, the contours here suggest a relatively symmetrical N100 response. However, keep in mind that particularly in kids is, and I do emphasize particularly in children, that is the exception rather than the norm. By and large, most children during this task will show a very poorly formed M50 N100 N component. You could see in this patient's profile of a single channel, it's very disorganized. Now, these are linguistic stimuli. They're not pure tones. They're physical parameters. Their fundamental frequency is different than what you might get in a pure tone. So the expectation that it will elicit a very clear primary sensory response should be tempered. It's very unlikely that you'll see this in a lot of subjects, at least it's our experience. So nevertheless, you can see that the late field component is present, and that's really what the portion that's of interest for us to perform our source localization on. Of course, looking at the final average will give you a good indication of whether you would have seen excess interictal discharges. For example, you'd see very time-locked activity in other regions that might be the suspected irritative zone. For the same reason, you might see larger deflections over the frontal channels if there was excess eye artifact that the filtering might not have gotten rid of. So generally, this represents this one represents an ideal signal. This one represents more the realistic signal that you would obtain in a child, at least based on what we see. So source localization of late component, really the principal reason why we we want to perform this. What does it look like, basically? What is it that what does that light field component look like? And our approach on localizing this is based on single equivalent current dipole that are fitted successive time samples during the late portion after the resolution of what we assume to be the primary sensory response. So about 200 to 800 milliseconds, sometimes going up to about 1 second. So here we see a nice reproducible response. We see a very, again, this is very ideal. So we have the early sensory component, and we bracket off the late field component. So how is the brain processing the perception of the words? What are we seeing? So upon looking at the contours, so this is a single point in time, you can see a stronger gradient forming in the left hemisphere temporal regions compared to the right. And over time, you'll see slight shifts topographically in the location of this dipole, each representing most likely activation of different areas that form clusters of dipoles on which the profile of activity would be based on. Fitting those dipoles, this is something that we would like to see form, really in the dominant hemisphere engagement of posterior, superior temporal, middle temporal regions, and oftentimes not represented here is engagement of mesial temporal regions in the dominant hemisphere, whereas in the right hemisphere you might have activity that's either homotopic but very sparse in terms of distribution of sources, or sometimes just confined to the auditory cortex. Now, there are several things. This is perhaps the most important slide, in my opinion, during the course of this discussion. The language, particularly as it pertains in kids, is more bilateral than most of us would think. So compared to individuals who might be used to looking at solely at fMRI activation maps, MEG is likely to give you much more discrete sources. So by implication and by definition, it's not uncommon to see language regions, homotopic language regions in the non-dominant hemisphere. So this becomes important when considering how dominance is established. It could be very well the case that you might have greater relative activation sources clustered to one area in the right hemisphere, whereas you might have less total activation sources in the dominant left hemisphere, but spread out into 2-3 separate clusters. Now, while the relative amount of activation may differ, the spatial distribution is what's important. So really the basing laterality judgments should consider going beyond just traditional means of calculating an index based on relative differences in the activation, the amount of activation per hemisphere. So really, given the temporal unfolding of these processes, it's very important to keep in mind how judgments are made about the engagement of regions. So again, using it simply for the sake of saying which hemisphere is dominant is one approach, but really if one wants to have a good appreciation of how distributed and what the extent of language-specific cortex is, it's very important to keep in mind these caveats. how reproducible are language-related fields using this paradigm? So here we have a representative waveform that shows over 4 trials, remarkably similar trends in activation. So you have the early component and you have the late field component. You can see that there's fluctuations slightly, not in the direction of the flux, but somewhat in amplitude and during the temporal progression, and it seemed to tail off towards around the same time. Using the single dipole analysis, we see that there's a very nice spatial overlap in activation sources in both hemispheres. You can either do this visually or probably more objectively apply something like a centroid analysis to look at the spatial overlap of dipole clusters across successive runs and choose the interpretation based on that. So you might have 3 out of 4 runs to show remarkably similar or identical spatial overlap that helps you have some confidence in making judgments about how well this particular task has been able to map language cortex and provide you with an estimate of a laterality. So what are some of the clinical indications? Well, obviously, you might have a case or a patient with a tumor. You might want to look at the proximity of the receptive language cortex relative to that, or if there's a massive space occupying lesion, how much shift has occurred in those areas. You know, other cases you might have individuals with focal onset seizures where if surgery is an option, you might want to see what the proximity of language areas are to the irritative zone, or is it the case where in patients who might experience aphasia or language deficits of the sort during seizures, or might have disrupted processing of speech, might be an indication of the overlap between frequency of interictal discharges or their proximity to language regions. And perhaps more interestingly is cases where you might see a growth shift in dominance. So here we see, I believe this patient had vocal seizures that were secondary to a left MCA. And you can see there's a clear shift in dominance. There's all the obliteration of the tissue and the dense cluster of interictal discharges. You can see sparse activation in the left hemisphere, and you can see a clear shift to the right hemisphere, engaging sort of the analog of Wernicke's area in that. So these are typically in cases where lesions are prominent. This is where language mapping become very useful, but I have to say that by and large, a lot of the patients that we do get referred for MEG testing and do have functional mapping performed are not necessarily surgical candidates. So it can also give you information about really how is receptive language represented in a given patient. And it's always interesting to keep in mind along the trajectory of their development and how that fits in with their neuropsych profile. So in some ways it might be an indirect, I wouldn't say a validation, but a complement to what might be determined to be a behavioral hallmark of patients with certain types of epilepsy. As I told you earlier, there are, with the exception of tonal languages, might be a bit more challenging to map. We do use a non-English variation in this task, and you can see that from these representative waveforms are not too dissimilar to what we saw in the second to last, previous slide. And using this, we're able to also elicit activation in superior middle temporal regions quite reliably. We don't use this often, but we do always have it on hand in patients where English is not a first language, or it's not uncommon for us in bilingual kids when the occasion arises and they're able to cooperate to actually do the task in both English and Spanish. So exceptional artifacts. There's the typical EKG, EOG, myogenic artifacts that one would encounter, particularly movement-related artifacts that one might see in kids. But in patients where there's an excess of epileptiform discharges that are essentially time locked or too frequent to overlap with the presentation of stimuli, is something to keep in mind. This doesn't happen very frequently, but it's not, I wouldn't say it's unfamiliar to us. So here's a representation of frequent interictal epileptiform discharges during the course of a performance of this task. And the top panel is MEG traces, and the bottom is surface EEG that was collected simultaneously. And essentially, the localization of the interictal discharges falls within this posterior quadrant. Unfortunately, averaging the signal also gives a similar gradient. So these are a unique thing to keep in mind that might influence spatiotemporal profiles of activation that you're trying to map. So hence going back and looking at single trials where you might suspect that the patient performed well during the task, but what your yield is might be influenced by some other factors that are not relevant to or typically wouldn't be seen. In the case where you source localize that, here's a patient with a bilateral perisylvian polymicrogyria. You can see that clustering of the language sources is remarkably similar to the cluster of dipoles that define the irritative zone. So it becomes very difficult. Of course, you might use advanced statistical techniques to decompose that out of the data, but given language-related fields and their inherent nature, you risk removing that signal of interest as well. Being a pediatric center, I'll just touch on this. I know we're on a budget for time. Determining the need for sedation. It's not uncommon for us to require sedation just because of the type of patients we deal with and the age ranges, but mainly having to do with behavioral issues. There are several factors that determine why a patient would need sedation. How necessary is it to do language evoke fields in these patients? In cases where it's absolutely necessary and there's no recourse to doing it using any other modality or being able to obtain very reliable neuropsychological assessment, we have to try something to be able to have some representation of how language is organized. Now, taking into account all of these factors that are on this slide, it's not uncommon for us to attempt this. And, we published a series of this a few years ago where we see that, we have some appreciable success in sedated and non-sedated patients and being able to map language cortex during light levels of sedation. That's typically the way we do that. I don't want to spend too much time on this. Perhaps it's something we could discuss at the end of the talk. For those that are interested, is about 80% of the time we're able to obtain activation in language-specific regions. Of course, you risk not having the cooperation of the subject, but we do turn off the sedation towards the end of the session and attempt to do this while the patients are waking up. It isn't always successful, but as I said, about 80% of the time we're able to obtain something meaningful in terms of, but with the caveat that, and interpretation being stipulated by the fact that this was done under a very low level of consciousness, and to sort of hedge our bets, as it were, and corroborate this perhaps with functional MRI, had similar mapping been done under sedation to see if there's a spatial overlap, or in cases where they might have undergone TMS as well. So again, this is something unique to us being a pediatric center, but this is just a snapshot of how we would use this in true passive mode in patients with sedation and what the yield would be. Mind you, again, this particular panel is in radiological convention, so unlike the other ones, left is right and right is left. So it's not a case that the dominance is shifted. All right, we've talked about looking at obtaining our language-related field profiles based on and modeling them based on equivalent current dipoles. As I said very early on in the talk, language mapping and language is a cognitive process. There's a great degree of variability, and there might be non-systematic variations of the signal that are associated with other operations that the patient might be performing, not necessarily specific to receptive language per se. So some years ago, we did a comparison of using single dipole comparison to time frequency analysis in beamformer, and actually found that about the 8 to 12 hertz range, you can localize Wernicke's activity with area activity with this task, based on this event-related desynchronization, and the results were as comparable to determining location and laterality based on single dipole. So of course, to do this, you'd need longer baselines than what we would use to be able to capture the low frequency component. But if the means are available to the user, it's always a nice comparison to have to ECD modeling. And given that you're looking at things in the time frequency domain and sort of in a more nonlinear dynamic, as it were, perhaps even tease out areas based on event-related synchronization or desynchronizations that might not be visible to a single dipole, that might sort of be lost in the averaging of the data. So keep in mind that there are alternative ways of looking at. So how valid is MEG for determining laterality? Series of systematic studies comparing it to WADA show almost excellent concordance. Similarly, if one was looking at validation of the extent of the cortex with electrocorticography, we'll see comparably good co-localization with particularly posterior temporal lobe regions using this specific task. So what's the current consensus? Well, there's a high degree of concordance, as we just discussed, with gold standard. So it does justify the utility of using MEG for language mapping in clinical populations. The high degree of reproducibility, not just within subjects, but across subjects, at least gives us some confidence that there's robust, efficient, and expedient ways of using this paradigm for obtaining meaningful profiles of language and actually assessing dominance. So, what's unique, of course, to MEG being able to use the same modality to localize the irritative zone. We have one approach, at least, where we can co-localize the extent of eloquent cortex relative to epileptogenic tissue or space-occupying lesions using a single modality. And to some degree, we're able to do this passively, particularly in patients who require sedation, where otherwise there's no recourse to performing it any other way. And the rich temporal information that's included in the MEG signal that might not be detectable by other modalities lends itself pretty well to being able to look at more nuanced mechanisms of language processing and perhaps looking at things at a network-based approach, for example, using connectivity to obtain a more comprehensive representation of how language is represented in the brain, particularly if one's to accept the argument that it's more bilateral than people think it is, and the distribution of the hubs that encompass the networks are a bit more detailed than one would take for granted under typical circumstances. So one thing that's obviously lacking is the standardized protocols across users. Again, there's no right or wrong way to do this, but each center for their own purposes have determined or used tasks that are able to yield robust results in conjunction with the analytical methods that they use. Again, using a single dipole model might be an oversimplification because we might be overlooking dynamics that might be able to quantify sort of cortical signaling and quantifying language on a network basis. One thing to consider is maximizing MEG based on the complementarity of using alternative techniques like functional MRI and TMS that sort of can act as another method of validation, but also give a different perspective on how language is organized based on the way they tap into those specific mechanisms. So really looking at commonalities between networks and differences that might not be visible by MEG in particular. And lastly, perhaps most importantly, is really consider how we interpret the results. Basically, knowing what we know and what we've been able to formulate over time, how cut and dry is the representation of language? Do we just go beyond looking at laterality based on the traditional method and looking at really how distributed language networks are and how these might be established, at least in younger individuals or clinical populations, where there might be some underlying parameters that cause sort of a deviation for the normal variation of language representation in typically developing individuals. I think it's safe to say that this presents a particular challenge, especially in kids who are at a developmental phase or might have some sort of organic underlying condition where there might be these incipient reorganizations in speech. And really the pictures that we're obtaining representative of those behavioral changes or things that behavioral tests might not be able to pick up so easily. So thank you very much. I know we're a bit over time. There's a lot to take in, but I hope that's going to stimulate some discussion among some of our attendees and even force us to kind of rethink and see if we can improve on the way that we've been doing things. You know, oftentimes people are ingrained in their approaches and tend to follow what works, but that's not to say things can't be improved or elaborated upon. So with that, I'll just pass it over to Nicole to initiate the discussion, and we'll take any questions that participants who've generously invested their time in sitting in can go ahead and ask.
Thank you. So I think we have time for one or two questions. So I will just first ask, what are some challenges that are often encountered when performing MEG language mapping in pediatric patients and the contingencies in place for trying to address them and maximize the yield of testing?
So in general, children tend to be, again, this becomes more of an issue in cases of developmental delay or patients who might have difficulties with information processing. That doesn't, I wouldn't particularly put a child who has ADHD in that class per se, because that's a behavioral condition where children can be coaxed or worked with and to be able to cooperate with the task demand. In kids, our best approach has been to do a titrated version of this task, and in cases where it proves difficult, we do perform the task passively and really providing placing a high task demand on kids can often backfire and cause them to become flustered. So we found that doing this passively might work best, and really obtaining several replications to be able to obtain the most consistent profile, to have at least some confidence regarding the judgments that we're making based on the test.
Okay, so next question is, what criteria do you use for rejection of single trials?
Generally, epileptiform discharges and the frequency that we discussed. Ideally, you'd want them, you know, if the electrographic discharges are to the point where they're as frequent as we saw in the two examples, then the data might not, you know, we might not consider using it. In terms of looking at eye artifact, typically if you're using the MEG software, Max Filter does a pretty decent job of reducing that and the EKG artifact from the signal, provided that it's not very frequent and saturating the signal. So basically visual inspection, what are you comfortable with, and how many of those trials do you reject based on those criteria to be able to still retain about 115 to 120 trials to keep into the average. So frequency of intracranial discharges, saturation of the background rhythm. So if there's excess alpha that's very prominent, in a single trial that might have to do with the patient's state of arousal might cause you to reconsider the quality of the data. So when you see that you're sort of exceeding the 10 to 15% trial rejection mode, it might be worth reconsidering either repeating the task under different circumstances on a different day if you have the means to, or reconsidering what the quality of the data is.
Well, thank you very much for presenting this masterclass today, Dr. Roozbeh Rezaie, and thank you everybody for joining as well. We hope to see you all at future MEG masterclasses.
Thanks very much for your time. Thank you.
Bye.